You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is March 28th, 2025. This is a part of our clinical immunology series, and today we will be discussing antibody deficiencies. This is presented by Dr. Nikita Raje and Dr. Tao Lei. They are both allergist immunologists at UMKC and Children's Mercy Hospital in Kansas City, Missouri.
This is our second lecture in the clinical immunology series, and I'm excited to have Dr. Tao Li with me as well, and thanks to her for all the hard work on creating this presentation. So we'll take turns in presenting this talk, but we are hoping, both of us, that we can go over a few topics, clinical topics, since we are done with our basic immunology. Dr. Lee, do you want to add anything to that?
Nope, I think that pretty much sums it up, and hopefully everyone finds this helpful, and just give us some feedback if you feel like it was helpful or some things that we can add as well, but I think we have some good plans moving forward. This is somewhat interactive, so we'll go ahead and get started with the case. So for this, you're just about to leave your Friday clinic when you get paged by the Gen Peds team about a 3-year-old boy who is admitted with acute hypoxic respiratory failure due to recurrent pneumonia. His blood cultures are pending, and they're wondering if the patient needs an immune workup because they're considering giving him IVIG because he's not improving. You decide that this patient needs you, so you're going to go see the patient as a consult, not just as giving some advice. After talking to the parents, you gather the following information. Regarding his immunology history, they feel like he gets a viral respiratory infection at least monthly with fever, congestion, and cough and nasal symptoms. He's had at least 2 of them diagnosed as flu, RSV, and COVID each. He hasn't had conjunctivitis before. He's been diagnosed with sinus infections at least 3 times. He's also had several ear infections before and has had at least 2 different sets of ear tubes, with the most recent ear infection about a month ago. He's had pneumonia 3 times, and he's currently admitted for pneumonia of the right lower lung. He's also been bacteremic once before and grew strep pneumo in his cultures. He has not had meningitis or bone or joint infections. He's had impetigo once before, and then he's also had thrush more so as a baby, but none since then. No fungal infections, no warts, and no urinary tract infections. For his past medical history, parents report that he's just kind of had a chronic wet cough for about the past year, but he's never been diagnosed with asthma before. For his past surgical history, he's just had the ear tubes that have been placed twice. And for his birth history, he was born full term without any complications during pregnancy or delivery, and his vaccinations are up to date. For family history, they're not sure of the diagnosis, but they say that the patient's cousin gets sick a lot and also is hospitalized all the time. For the social history, this is the first and only child for the parents, lives with both mom and dad, does not have any pet exposures at home or exposure to any smoke. On physical exam, temperature 99, not quite fever yet, heart rate 95, and BP is stable, respiratory rate 35, and he's on 95%. His oxygen is 95% while on 2 liters of nasal cannula. His growth has been 12 percentile and length 12 percentile, so tracking along his curve since birth. Overall appearance, he just chronically looks ill, but he's not in any acute distress. For his head and neck exam, normocephalic, atraumatic, and his ears look normal, nares are patent, and then his oropharynx is clear, no significant erythema or exudates or petechiae, but you can't really see his tonsils, and he hasn't had a tonsillectomy before. For cardiovascular, he is a little bit tachycardic, but there's a regular rhythm. There's no murmur appreciated, and he has good cap refill. On pulmonary exam, he has crackles that are appreciated in the right lung base, but he sounds pretty diffusely coarse with some mild retractions on nasal cannula. On abdominal exam, soft, non-tender, non-distended with good bowel sounds, extremities, no peripheral edema or notable cyanosis, and overall skin exam was pretty unremarkable without an acute rash. So based on the history and physical exam so far, what is the most likely diagnosis?
I wouldn't think selective IgA because not a lot of like mucosal infections. I wouldn't think transient hypogam of infancy. I think usually it resolves like by age 2, so that's why I don't think it's the. Could be AGAM. I'd want to see other labs for like CVID, things like that. So I think labs would be helpful to see, but I think it could be C or E.
Manali, what are you thinking?
I agree with Michelle. I feel like I could go towards CVID. But in terms of like specific antibody deficiency, like I said with Michelle, you have to like get labs. So I'm leaning more towards E, so I'll go with CVID.
All right, Michelle, is that your final answer?
I don't know why I'm between C and E, but I'll go with. I need labs.
Well, okay. Are we going with E?
If Michelle feels strongly towards C, sure, I'll listen to her and go with that. I trust. I'm not sure of the difference, so yeah, we can go with C then.
All right. Strong choice. When in doubt. So C is the correct answer for AGAM. And so we'll go through each of these different differentials to talk through kind of the overall incidence, some of the suspected pathogenesis and the clinical manifestations, and the kind of pertinent labs or physical exam findings that may be helpful to help kind of clue you in. And I think if you were to go back onto this case, there's a couple little subtle hints that may point you towards answer choice C as opposed to E. So first thing we'll talk about is AGAM.
Awesome. All right. A good choice. And yeah, let's start with AGAM. So A-gamma globulinemia, as the name suggests, that there is no gamma globulin, and so it is defined by the immunoglobulin levels as well as the presence of B cells. So the levels of IgG are defined as less than 100, IgM less than 20, and IgA less than 10. But the bottom line is there are no peripheral mature B cells in the circulation. So less than 2% of CD19 positive B cells when you check. But we'll go into the details in a minute here about how we define presence of B cells or absence of B cells in these patients, right? We clinically know that there are no CD19 positive B cells when we call it AGAM. So because there are no mature B cells, the expected immunoglobulin levels are pretty much undetectable. Depending on the lab, the detectable level of immunoglobulins can vary. For example, for IgA, some of the labs will tell you if the IgA level is above 30, it will give you a number, but below 30, it will say less than 30 because they cannot detect anything below that. Other labs go up to 7, including ours, and it will say IgA 10, 15, 20, 30, or it will say less than 7. So below 7, it's undetectable because that's the level that our lab can go up to. And then there are labs that go less than 1. So similarly, for all IgM, IgG, IgA, there are levels below which they are undetectable. So technically, if you think about AGAM, the meaning is that there is no gamma globulin, and that means there is because of the lack of B cells. So the differential includes CVID. If it's severe form of CVID, it may start early. However, there are specific criteria for CVID that have to be fulfilled. We are not going to be talking about CVID today because we thought it was a bigger topic that would need more time. So we were going to have a full discussion, a full hour of discussion on CVID and infusions later at a later time. But again, if you think about AGAM, you have to wonder what the inheritance is, whether it's X-linked or autosomal recessive. The most common genetic cause of this rare disorder is X-linked A-gamma globulinemia. When you suspect AGAM, you are if it's a boy, you are typically thinking of X-linked agammaglobulinemia caused by a defect in the gene called BTK, and it's also known as Bruton's agammaglobulinemia, as you know. But if it's a girl child who has similar features, you should still think about possibility of AGAM, because now we know that there are some rare causes of autosomal recessive AGAM. Let's move. All right, so X-linked agammaglobulinemia or Bruton's agammaglobulinemia is pretty rare, 1 in 100,000 or 1 in 200,000, depending on the cohorts you are looking at. As mentioned, this is due to the defect in a gene called BTK or Bruton's tyrosine kinase. This results in the rest of the B cells, B cell maturation. As you can see on the right here, we have this figure from Abbas. And we want to kind of go into a little bit of detail. I know it's a clinical talk, but still, I feel like the base is very important to know, because this also helps you in answering some of your test questions, as well as kind of having that foundation of what's going on, right? Like, where is the arrest of the maturation? Because that will tell you what to expect, what markers would be present in these cells. So you may see B cells in circulation, but these are not mature cells. And so kind of going a little bit into this development of B cells, we know that the B cells come from stem cells that become pro-B or pro-T cells, and then the pro-B cells will become pre-B cells and then move further into maturation. So these pro-B cells, if they are able to progress to make the B cell receptor, they are going to mature into fully mature naive B cells that can make antibodies. For them to do that, the first step in making that B cell receptor on the surface to be a functional B cell, they need to rearrange their gene segments called VDJ rearrangement to make a B cell receptor on an experimental basis, or just kind of trying it out, and that's called a pre-BCR or pre-B cell receptor. When they make this pre-B cell receptor, it is one of the important checkpoints in maturation. It's almost like a test that these B cells get that they have to pass. If they pass the test, they are able to proliferate further and mature further. If they fail that test, their maturation is arrested right there at the pre-BCR or pre-B cell stage, and there is no further development of those B cells. So if they cannot develop or express pre-BCR on their surface, they are going to die, as this figure suggests here, right? If they are able to express the pre-BCR on their surface, then they move on to proliferation. So they make more of those. And then the pre-BCR, if you can see, once it is successful, it's a successful VDJ recombination, it's going to move on to make the final BCR, the true BCR that's going to be on the surface of those B cells, that's going to go out in the adult world and just, look for any antigens that they can bind to. And that's your BCR, right? B cell receptor on the surface. But there are some immature stages of development before that. So pro-B cell becomes a pre-B cell, and then pre-B cell becomes an immature B cell that has an IgM or the BCR on its surface, and then eventually it can go into the periphery, right? This is all happening in the bone marrow, but then the immature B cells are released into the circulation. They go on to they move to the secondary lymphoid organs like spleen, and there they complete their maturation to have IgM and IgD on their surface, which would be a mature B cell. Once that mature B cell is in the circulation, it's still naive, which means it has not come across the antigen that it's specific for. So that's the developmental phase. Now, at the stage of pre-BCR is where the BTK is an important factor. The pre-BCR, when it's formed, it has to show that it's functional. And the way it shows that it's functional is the self-antigens come and attach to that pre-BCR. And if they are able to attach to the receptor and the receptor is able to signal through the downstream of it, then it's called a functional pre-BCR, and the downstream signaling is through BTK. If there is a functional BTK and a functional pre-BCR on the surface, then the signaling goes through and they pass the test so that they go on to the next stage of development. If the BTK is defective or the pre-B cell receptor is defective, that signaling doesn't go through and the cells die. So that's what happens in AGAM. If in X-linked AGAM, BTK is absent or non-functional, because of which the development of B cells gets arrested at the pre-BCR stage or pre-B cell stage. So there are no mature B cells in these patients. And so you expect that these patients wouldn't make immunoglobulin. In clinical practice, though, you will see that some of these patients have clinical heterogeneity, which means that some of these patients typically should present around 3 to 6 months age, where the maternal immunoglobulin is reducing in the circulation and the baby's immune system is not capable of making mature B cells and antibodies. However, there are some patients who will present later at a later age. And then somehow you see that some of these patients will not actually meet those criteria where their immunoglobulins are completely undetectable. So they will have some immunoglobulins, which is kind of puzzling in a way if you think about it. But now, if you recall from Abbas, we have different types of B cells, right? We have the follicular B cells, which are the ones that we are talking about here. But then remember, there are some B1 B cells that came from fetal liver instead of the bone marrow. And there are those marginal zone B cells that are not the typical follicular B cells that we are talking about here. So there are some B cells that might still make some antibodies somewhere. We don't know if those are enough for a function. So we would still think that if you see X-linked AGAM and you prove that a patient has absence of BTK, you would still expect those patients, regardless of the immunoglobulin level, to have symptoms. So some of these patients will have infections, if not at an early age, maybe a little later. The good, something that can actually help with earlier diagnosis is family history. And family history is really important in all IEIs, not just XLA, but just kind of keeping in mind that here, the family history is very typical, where the males in the family are affected by frequent infections. And maybe you have to ask about early deaths in the family, and you will see a pattern in the family that you may have heard of in the case before. So one of the things that can kind of be a clue for answering questions is, are they talking about a male child or not? Like, is there family history, and is that also male? So kind of picking up on the inheritance is, are they talking about X-linked, or are they talking about autosomal recessive if they talked about girls and boys affected in the family? So just kind of paying attention to those minor details in the question can help you a little bit. All right, next slide. Awesome. So clinical manifestations. So we talked about how these patients can present with infections. We know that these patients with antibody deficiencies can present with lots of bacterial infections, some viral infections as well. But typical hallmark presentation of XLA is recurrent pyogenic bacterial infections that occurs in early childhood, so in infancy, in young boys, right? So that should give you a clue. If you see that kind of picture in the test or clinically in your patients, think about XLA. Yeah, here we are showing the data from USID Net Registry. This was a cohort of 226 patients, and all these patients with XLA had various types of bacterial infections, the most common being ear, nose, throat infections in 78% of patients, and then lower respiratory tract infections in about 73% of the patients. Common bugs that you might find are strep pneumo and H flu. But as you can see, there is a long list of infections or microbes that you see here, not just bacterial, but even viral infections. Some infections by that you might think that those are almost going towards opportunistic, like Mycobacterium avium. So there, some of these patients have, or this cohort had shown some atypical infections that you would not typically associate with XLA diagnosis. But for most part, think about pyogenic bacterial infections, and just kind of think of XLA in your differential. Exam, again, most of the times the exam might not be as prominent that you would pick up on any particular signs. But thinking of a young child who doesn't have tonsils or lymph nodes, I think one of the diagnoses that should come to your mind is XLA. Now, typically you think of XLA as an antibody deficiency that presents with infections, and that's about it. But we know that XLA patients are still at risk for having non-infectious issues, such as bronchiectasis, especially due to the recurrent lung infections, they may develop bronchiectasis. But also they can have some autoimmune features that have been described. So say you have a patient where you are suspecting, well, say we talk about the patient that we just presented, and we don't know what this patient has. We think it's, our top differential is XLA, but you would still have to think about, okay, is this a patient who has, does the patient have B cells or not have B cells? Does the patient have immunoglobulins or not, right? We see so many patients that with recurrent infections that you would really need lab data to make that diagnosis. So in patients with recurrent sinopulmonary infections, typically you would get your basic immune workup, your CBC differential, your lymphocyte counts, immunoglobulin levels, antibody titers, vaccine titers, and if all of these are pointing towards an IEI, then you might consider genetic testing. So when you go back and think about what you would find in XLA patients, typically your CBC differential can be normal, but in 10 to 25% of the patients, you may find neutropenia. So thinking about patients with low immunoglobulins and neutropenia, XLA should be something that should come to your mind. Immunoglobulin levels would be low, and there would be lack of response to vaccines. Now, if you have that picture with neutropenia, low immunoglobulins, and low vaccine titers, your next step should be looking at flow cytometry to see if your B cells, if there are mature CD19 positive B cells in circulation or not. If those are absent, your suspicion would be agammaglobulinemia in a boy. If it's a male child, I would say your next step should be just checking for genetic testing and functional testing for BTK. And this is one of the few times where you could get a single gene testing. Typically, when you are getting genetic testing in case if you are suspecting IEIs, I would say you would either go for a panel or exome testing. But there are few patients where you have very high suspicion, say family history of agammaglobulinemia, male child, absent immunoglobulins, absent B cells, your suspicion for BTK is so high that you might want to start there. And if that's negative, you can send a panel. So kind of keeping that in mind. In terms of functional testing, it can come back pretty quickly, but it's only available at certain academic centers. So you would order looking for BTK because BTK is absent in B cells. However, it's tricky because your B cells are absent. How are you even going to perform the test on a cell that's absent? So that's where you would actually go ahead and send your peripheral blood, and they do the testing on monocytes because typically your BTK is also expressed in B cells as well as monocytes. So you would see absence of expression of BTK in these patients' monocytes, which is what we are showing here in the panel on the right, where you see that there are all right, so let's see here. There are lymphocytes, and you see the expression of BTK, which is, let's see, I'm trying to make sure I'm understanding this right. So here is a patient where you are not seeing BTK in this right upper chamber here, yes. And then in the normal patient or normal subjects, you do see the presence of BTK. And then in the mom, you would see lymphocytes that have presence of BTK presence of lymphocytes, but the BTK might be on the lower side because they have one set of genes that are able to make that BTK. The second panel B is for monocytes, where it's showing that there is presence, or the shift of that histogram showing the presence of BTK with fluorescence, versus your patient population. There will be no shift in that graph for showing the fluorescence for the BTK. In mom, you'll see two populations, one with presence of BTK and the other there wouldn't be a shift in those cells. So that's your functional assay, which is available at some academic centers, and you could do that before the genetic testing comes back. Your treatment is, as we know, is immunoglobulin replacement. You may have to consider giving them prophylactic antibiotics for certain patients with XLA. More and more, we see that their infections can still be present at a lower frequency while they are on immunoglobulin infusions, and prophylactic antibiotics might actually help with those infections, especially lung infections. And then when these patients are on infusions, we suggest not, live vaccines are contraindicated, but again, the inactivated vaccines, you could give them those vaccines. I don't think there is any evidence or lack of evidence of any kind of response to the vaccines. But the question is, if there are normal functioning T cells, would there be some T cell response to those vaccines? So we do not. So the inactivated vaccines are not contraindicated, but once they are on infusions, it's their choice. I do think that the live vaccines are completely contraindicated, so those are not to be given while they are on infusions, or in case of XLA before treatment. All right, that's for XLA. One of the things that I wanted to mention about XLA is enteroviral encephalitis that you might see in patients with XLA that has been noted. Moving on to autosomal AGAM, these are again even more rare compared to XLA, can be more severe, they can present early, and these patients can have defects in other regions other than BTK, but the bottom line is they are not able to progress from the pre-BCR stage of development. So the B cells are arrested in their maturation beyond that stage. And so that's what defines the A-gamma globulinemia. So what happens in autosomal recessive patients with AGAM? So these are some of the genes that can be affected. Mu heavy chain. roughly about 5% of the cases have this mu heavy chain that's affected. Remember, the pre-BCR is formed of mu heavy chain and a surrogate light chain. So if that's defective, the pre-BCR is not well formed and cannot signal through the BTK, and that's where they are gonna develop the XLA. These patients again can present with enteroviral infections, pseudomonas infections, lambda phi, that's the surrogate light chain of the pre-BCR complex. So the mu heavy chain combines or associates with the surrogate light chain to form the pre-BCR. The BCR itself is formed by IgM heavy chain and light chain, so IgM molecule on the surface. But the pre-BCR is made up of mu heavy chain with surrogate light chain. So if that's defective, again, you have AGAM. Ig alpha and Ig beta are the two chains, CD79A and B are the two chains that are required for signaling of the BCR. So if those are defective, the signal doesn't go through, and again, that causes AGAM. Blink, remember in BCR signaling, you have your tyrosine kinases that go through that whole process of signaling, and then they have to attach to a adapter molecule, as like there is LAT in T cell signaling, there is Blink in B cell signaling. So if that's like a platform on which a lot of enzymes come together, and BTK is associated with Blink, and if that's defective, then you again have problem with intracellular signaling. And one of the important ones I would say is PI3 kinase. PI3 kinase defect is causes a problem with survival of B cells, and so you will have AGAM. So PI3 kinase can have defects either in the delta unit of it or alpha unit of it. So the alpha unit defect, 85 alpha defect, is called PIK3R1 defect, and that can cause AGAM. All of these are autosomal recessive, remember.
Yeah, and I think it is good to recognize these genes and then tying it back into some of the basic parts of when you're going through kind of the development when you're studying. I think that was really helpful for me when I was studying for boards, is tying in some of these gene names to like conceptually their function so I could at least recognize it.
Absolutely, yep.
Okay,
All
so
right.
with hypogam, so now my turn. When we think about for hypogammaglobulinemia, so this can be defined as a serum IgG of less than 700. I did see that there were kind of various definitions of where that cutoff is, and there were some that had it as low as 600, less than 600 for a classification of hypogam. But deeper within that, you can also classify it into mild, moderate, or severe, depending on the level. I think that specifically for us working in pediatrics, it's important to kind of do it based off of the age. So for example, if you're getting a consult or referral from an outside physician or getting a call about someone, trying to ask the age of the patient to really assess if they truly have hypogam or not, as that can vary, and you'll see that on the table on the right. This was the reference range that we actually use here at Children's Mercy, which was taken from the Mayo Clinic. So I have it here, but when you look at your labs, if it's a patient in-house, it should be reflective of that. But again, if it's outside, you can go to the Children's Mercy lab test catalog and use that as a reference too. But when we think about hypogam, something to really kind of delve into of whether or not you think that this is going to be a primary or secondary, or also known as acquired hypogam. And that's where your history is going to come into play of whether or not if they're having recurrent infections, do they have other features, do they have a family history of IAI, do they have a significant history for like nephropathies or something that can also be familial, and then really looking at kind of all the different medications that they can be on, and we'll kind of delve into all the different causes of secondary hypogam. So as you can see here on this chart, it's a pretty broad diagnosis or broad differential when you're assessing these patients. And there were some newer practice parameters that were given as well to look into the evaluation and the management of secondary hypogam. But I know we've had some patients that we've either been consulted on with a history of nephropathy, and then they have hypogam, and then we kind of discuss what's the long-term management of these patients. So these patients that may have been previously on transplanted and on immunosuppressive therapies, other patients that we'll see outside of those that are having like a protein losing enterology neuropathy are those that have had chemotherapy, for example, or CAR T-cell therapy. And ideally with these patients, you would like to know, like, what were their labs before they started the therapy. When I was I guess not an intern, but my first year of fellowship, I had a patient that I was consulted on that had a history of ataxia telangiectasia. And the question was, is the hypogam a result of kind of like the immunosuppressive therapy that he was on in chemotherapy, or was it something that was with the AT in itself? And I think those are some of the things that we try to assess. And if you have baseline labs, that's helpful, but not always the case. But some things can be concurring at the same time. But again, I think it is important to have that broad differential as you approach these patients. And then I think with that, based off of the history, that'll help guide you of whether or not what additional lab work that you'll have to do. So outside of the typical things that we'll do for recurrent infections, if, for example, a patient has a history of pitting edema in their legs or something, then you may want to consider getting a UA to see if they're leaking protein into their urine. And for some patients, I know that we've even done like an SPEP, or if they're having a lot of kind of diarrhea, then maybe you want to consider getting like an alpha-1 antitrypsin study. And again, also kind of thinking about, does this patient have a potential of IBD, for example? So when we think about the management of secondary hypogam, it's a little bit different than our typical like primary immunodeficiencies or IEIs. You can actually consider using prophylactic immunoglobulin replacement therapy, especially if the immunoglobulin levels are less than 300 to 400, especially in patients that have had like anti-CD20 therapy such as rituximab, or if they've had like a stem cell transplant or CAR T-cell therapy. But it's kind of unclear because based off of the current data, there's like no clear recommendation of when to start. It's kind of like based off of, I think, a lot of shared decision making of the clinician, the clinical picture of the patient, and what the family feels comfortable with. Outside of the prophylactic immunoglobulin replacement therapy, especially if the patient is having like an ongoing issue and it hasn't been resolved, the question is, sorry, one second.
Oh, sorry, Robert.
Sorry. Whenever you have like, what was I saying? Oh, okay. So I think it's hard because whenever you're looking at these patients, and if they're having like ongoing renal disease that hasn't been controlled, you can consider starting subcutaneous immunoglobulin therapy, which can be preferred and better absorption in these patients. But the question is if they're having uncontrolled disease, how much is that number really going to improve? And by whatever amount that they do improve, is it going to have like clinical benefit or therapeutic? Does it even get to therapeutic ranges? But I think that's a discussion that you have with the family, and you'll just have to do like continued monitoring. For management of secondary hypogam, you can also consider doing vaccination, but the question is depending on what you think is causing their secondary hypogam, if they do get the vaccines, will it really be beneficial, or will their response be blunted because perhaps they're on ongoing immunosuppressive therapy, or they don't have any B cells because they've had anti-CD20 therapy and it hasn't repopulated. So I think you'll again have to reassess, do we think that this is going to really benefit them or not? Another consideration that you can do is consider doing prophylactic antibiotics. And so there's a separate slide later in the talk about the common antibiotics that we'll use for prophylaxis. This I thought was just kind of a helpful algorithm that I took from the secondary hypogam practice parameters. So obviously you would start off by looking at their IgG level, and if it was less than 150 or not, you can kind of go down this pathway. If it is, because then that would kind of fall into the severe category, then you can consider doing immunoglobulin replacement therapy. But what you'll want to do is kind of do periodic assessment, and as always doing shared decision making. If not, you can assess whether or not they have low immunoglobulins in terms of IgA or IgM, or do they also have inadequate vaccine responses, or if the IgG in itself is less than 400. If yes, you'll use your kind of overall clinical history to see if they're having like pretty severe infections that are frequent, or if they're requiring a lot of IV antibiotics or hospitalizations. Again, ultimately goes down this shared decision-making pathway. If not, if they're kind of less than 400, but otherwise clinically doing well or not frequently on antibiotics or in the hospital, then you could consider doing monitoring every 6 to 12 months and then reassessing whether or not they need the immunoglobulin replacement therapy, or perhaps they may have a change in terms of their underlying condition that's contributing to their secondary hypogam. I think another good thing to discuss is looking at transient hypogam of infancy, or THI. So as you recall, infants are usually protected by transplacental maternal IgG, especially in the first 3 to 6 months of life. However, what you'll notice here is that after that, they'll start to decrease as the infant's production starts to increase, and this figure was taken from a BOS. In THI, infants' production of IgG can actually take longer to reach normal levels, and it depends on the age of the child. In some cases, although we think that it's primarily just like low IgG, some patients can have like diffusely low immunoglobulins, whether it's low IgM in addition to the IgG and IgA. For several of these patients, however, they have their specific antibody production that's still preserved in addition to their cell-mediated immunity. During this period of hypogam, some of these patients may also have recurrent infections that oftentimes are sinopulmonary, so you'll just have to get a really good history of these patients to see what types of infections they've had and the frequency of the antibiotics that they've had as well. Most of the time, these patients with THI will resolve around the age of 2. However, some of them can persist up until at least 5 years of age. Every patient's a little bit variable in terms of like how their immune system will develop, so you really can't say that it's no longer THI if it still persists by after the age of 2, but it's still something that you'll want to continue to monitor. If the patient continues to have hypogam after the age of 5, then you'll want to definitely consider other causes. Some other things that you should have in the back of your minds when you approach these patients are things like CVID or specific antibody deficiency, which you would primarily see if you feel like they are not having an appropriate response to the vaccines. But if it's early in life, as Dr. Raje mentioned, especially if you're having like diffusely low immunoglobulins, then you would also consider AGAM. For some patients, you also should consider still severe combined immunodeficiency. While we do have the abnormal newborn screen that can catch some, a significant number of patients with severe combined immunodeficiency, we have had some patients that were diagnosed like later in life for something that was like not relevant at the time, as we've seen in our clinic as well. So, next slide. So in terms of for diagnosis for THI, you would pretty much, for when we see these patients, they're oftentimes coming in still with recurrent infections, or maybe they had an immunoglobulin level that was drawn by their provider, but you would still do the full evaluation with your CBC diff. You would still get your lymphocyte subsets. And you can also include getting a naive and memory B cell panel, which I'll go into, in addition to immunoglobulin levels and vaccine titers. When we think about the IgG, you'll usually consider it low if it's 2 standard deviations below the average level on at least 2 separate occasions. So certainly if they've had it once and it was low, don't just hedge on just that one, but get a repeat level later on, because as we've seen in some of our consults, sometimes these numbers can be low if they're acutely sick, or especially if they're in the hospital, septic or something like that, that can certainly alter those numbers. The reason why I mentioned about considering getting the naive and memory B cell panel was because I actually found an Italian prospective study that looked at these patients with THI. I think something that's important to note is that in order to truly diagnose someone of this, it's really kind of a diagnosis of exclusion, if you will, in the sense of you can only say that it's THI if you've proven that by the age of 5 or so, the hypogam has completely resolved on its own. Up until then, you can't really say that it's that, because you don't know if it could morph into something, if it's actually going to resolve by that time or not. So I think it's at that point, when you know that it's all normalized or doing better, that you feel more comfortable diagnosing it as such. A part of this Italian prospective study, what they looked at is 77 pediatric patients that were initially diagnosed with THI. Only 57 of them were able to be monitored, because they looked at this over a 3-year time period to really see, like, did these patients all resolve by that time period? Did they come up with a different diagnosis? Of the patients that did not normalize, so 16 of the 57, they found that they had low IgM, and they also had decreased class switch memory B cells in addition to low IgG. They also found that these patients that were found to have persistent hypogam after the age of 5 also had more severe infections, so like more frequent pneumonias, and also urinary tract infections and gastrointestinal disease, as well as some autoimmune components as well. So getting that overall history and trying to see if there's anything that's red flag may point you, this may persist longer than we think. For these patients with THI, in terms of the management, if those patients are asymptomatic, or depending on the frequency of their infections or antibiotic use, you can consider observation. It's not that you necessarily have to jump to doing antibiotic prophylaxis, for example. Now, some patients, if they're getting frequent infections, and especially if there seems to be a seasonal component, you can consider doing antibiotic prophylaxis during like fall and winter monitor, for example, when, especially if they're in school or daycare and they're constantly on them, then you can always try to see if that'll help. But you can always reassess these patients and see if they can do a trial off of it to see if they're going to do better. Because if, with antibiotic prophylaxis, there's always risk that comes with it too. They still should have frequent monitoring, whether it's labs, but also clinical manifestations. And so I think that that's something that you can consider doing as more of like a seasonal aspect as opposed to like indefinitely. With patients that have THI and they're on antibiotic prophylaxis, or maybe they're having severe or frequent infections with hospitalizations, you can temporarily consider putting them on immunoglobulin replacement therapy. But what I think is important to know or consider is not necessarily jumping to put someone on immunoglobulin, because in a way, it doesn't necessarily change like the natural course of THI, but it can in a way delay the further workup or really being able to identify, is this THI or is this some other form of IEI? While patients are on immunoglobulin replacement therapy, their numbers in terms of their like specific antibody levels, if you're looking at vaccine titers or immunoglobulin levels, may be more so because of the product in itself. And so you would have to wait at least 4 to 6 months after they've been off the immunoglobulin replacement therapy to reassess these numbers in terms of immunoglobulin levels and titers to see if this patient is truly persistently hypogam or if they have some other IEI. And then in terms of for long-term management, some of these patients can progress to CVID. I was trying to find like a good study to see perhaps like what ratio of that. And I think with this Italian study, these patients, I believe they all had either persistent hypogam and some of them did have a diagnosis of CVID. I will say that in my short experience so far, I have had a couple that had like initially thought to be THI, and 2 of them are now more formally diagnosed with CVID. And then we'll talk about selective IgA deficiency.
All right. So, selective IgA deficiency is pretty common compared to some of the other rare immunodeficiencies. It's estimated to be about 1 in 500. Depending on the cohort, you might see numbers like 1 in 300, 1 in 400. And then it can also it also depends on the ethnicity. So you will see some cohorts from, with different ethnicity who may have higher incidence that's noted. How do you define selective IgA deficiency? So again, as I had mentioned earlier, there are detectable levels of immunoglobulins, and for IgA, most of the labs go up to 7. So if it is undetectable IgA with normal immunoglobulin G and M in a patient who is older than 4 years, you define that as selective IgA deficiency. The reason why below 4 years age you do not want to diagnose patients with selective IgA is because that can normalize over time, thought to be just from the immaturity of the immune system, where the IgA can kind of move towards normal number after 4-year age. So you really want to make sure that the patient is more than 4-year age, and if the IgA is less, if it is undetectable. So less than 7 is our definition for selective IgA deficiency. For partial IgA deficiency, if you have heard of that term, it's floating around somewhere where you will see this term called partial IgA deficiency, where the IgA is higher than 7, but it's still below normal range for that age. And even though we say that, you might hear this term, really clinically, there is just no significance of that term, because if your IgG and IgM are normal and your IgA is higher than 7, you do not have to do anything for that. No monitoring that is suggested or any kind of management. In general, if you have a patient who is above 4-year age, IgA is less than 7, you may see that some of these patients are walking around fine, not knowing that they had IgA deficiency till you diagnose them. And most common scenario for these patients is where they get testing for celiac disease, and with that testing, looking for TTG IgA antibody, the test itself includes getting a total IgA level. And so a lot of these patients, when they are getting that testing, are noted to have low IgA or undetectable IgA, and then they are sent for further evaluation. Other than those GI issues that have them, because of which they are being tested for celiac. They do not have any other medical problems, they do not have infections, and they are pretty much walking around asymptomatic from this IgA deficiency. Well, there are others who are more severe. They have recurrent sinopulmonary infections, they may have GI infections. They are also at risk for having some atopy or autoimmunity or even malignancy. So non-infectious issues and infectious issues can be part of having selective IgA deficiency. Your lab work would include your basic immune workup, so looking for cell counts. You want to get lymphocyte subsets. I typically look for naive and memory B cells to see what those B cells are looking like, getting immunoglobulin levels and response to vaccines. You can also check for subclasses if you are in a situation where you are not sure if IgA deficiency is clinically relevant or not. And in some of these patients, your response to vaccines may be low, and that might be enough. At times, if that's a concern because you have the low vaccine response to boosters, and you don't see a response with the rest of the treatment, you may have to go beyond calling them selective IgA deficiency, where subclasses may be tested. Most of the cases, I suggest not looking for subclasses because that does not add to what you are going to add to whatever you are using to make your clinical decisions. But once in a while, if you have a patient where you check subclasses, you may see that the IgG2 subclass may be deficient. For IgA deficiency, again, anytime you see these patients with IEIs, treatment typically, yes, it depends on the diagnosis. It also depends on the patient and their presentation. If they are asymptomatic, there is no treatment needed, but monitoring is suggested. So I would suggest that these patients follow up in our clinic once in a year, once in 2 years, depending on what's going on. They maybe need to be monitored not just for infections, but the non-infectious issues as well. Now, rarely in the past, we thought that this was an issue where it was thought that if these patients with IgA deficiency get blood products, they may have anaphylactic reaction to those blood products because the blood products may have a little bit of IgA in them, and that could be considered a foreign antigen that has never been seen by this immune system that has selective IgA deficiency and may have an allergic reaction. This is considered a theoretical risk. We do not know if this has happened anytime recently. Regardless, it's rare, but something that patients may need to just be educated on. And there are medic alert bracelets that they can have if they are diagnosed. So something to keep in mind. Now, when we talk about absent IgA, we are really talking about less than 1. So if you have an IgA less than 7, you really don't know if it's 654 or something, 32, or it's completely absent. So if you are thinking if that anaphylaxis is a concern, you can always go ahead and send your IgA level to another lab that can run the test and see if it's really IgA less than 1 or if there is a little bit of IgA. And in those cases where you see even a little bit of IgA, the risk of anaphylaxis is not an issue at all because the immune system has seen IgA and will not react to those blood products. For patients with recurrent infections, you can consider prophylactic antibiotics. Some of them have excellent response to that prophylaxis, and see how they do. You would have to monitor them more frequently when they are on those antibiotics.
All right, so I feel like this is one that I've been seeing more often lately, but in terms of specific antibody deficiency. So this is characterized as a primary immunodeficiency with normal immunoglobulin levels, but these patients will have a diminished antibody response to our polysaccharide antigens after vaccination, and this will result in recurrent sinopulmonary infections, commonly strep pneumo and Haemophilus influenza, especially type B. I put this in there because I always think it's helpful to kind of remember what type of vaccines you you have, especially in terms of for the pneumonia vaccine, because sometimes we'll get a call, can we use this instead, or can we use this? So I think it's helpful to kind of know which type of mechanism it is and the type of vaccine. So with your Prevnar one, so your, I think 7 was before, 13, and more commonly now that we'll find is 20, that's a T-cell dependent process, and it's a conjugated vaccine, as opposed to Pneumovax, which is a T-cell independent mechanism, and it's a polysaccharide vaccine. So with these patients specifically, they can have a similar phenotype to common variable immunodeficiency. So I think that's why, in addition for these patients, you'll monitor them with time to make sure that their immunoglobulin levels don't change. Because as we kind of talk more about CVID and the clinical features and the diagnosis, you'll kind of find that some of these things have like some slight overlap. So I think it's important to know like what you're looking for, but then with time, does this actually become like a larger process than we initially thought, for example? So with specific antibody deficiency, we normally don't diagnose this until at least 2 years of age. And as Dr. Raje mentioned about all the different types of B cells, the main reason that I thought was helpful when I was studying was that those marginal B cells that are responsible for kind of in response to polysaccharide antigens don't really develop until the age of 2. So thinking about that, when you have these patients, if you decide to get pneumococcal titers beforehand, which I have done recently in certain circumstances where the patient isn't 2 yet, I get the pneumococcal 23 serotypes. I kind of want to gauge what has been their response so far to all the different doses of Prevnar that they've had. It's a little bit alarming to me sometimes when I find that they don't have a response, because that should be like a T-cell dependent, more robust response. And so when I find that they don't have really any, I'm starting to think, well, is there something here that's not specific to specific antibody deficiency? Is there an issue with T-cell function? But with this, what you'll kind of think about with specific antibody deficiency is that the underlying defect isn't necessarily clear, but there's been reports of also, again, those decreased switched memory B cells. I have found that lately, based off of kind of what I've been able to review and then just practicing by myself now, I've been finding that I've been getting a little bit more of naive and memory B cell panels in addition to my typical like lymphocyte subsets, especially in the context of patient if they're having recurrent sinopulmonary infections, and especially if they live further away. I try to get some of these labs that I think will be helpful for me for my initial diagnosis or more long-term management. So I think this was helpful just to kind of compare the different serotypes and what's prevalent in either of them. And so whenever you're looking at these titers too, I think it is good to kind of know, depending on like what you find that they've had a response to, if it may have been because they got PCV 13, did they get PCV 20 or PCV 23, and making sure that they have kind of like appropriate antibody levels to serotypes that you'll find that may not be found in one but would be in the other, to show that they've actually had a response to something seen in both. So with specific antibody deficiency, the diagnosis, there's some kind of different variations between the diagnosis based off of the European Society for Immunodeficiency, or ESID, compared to the US practice parameters. But essentially the main part of it is that these patients will have normal immunoglobulin levels, and they will also have an abnormal IgG antibody response to pneumococcal vaccine, for example. The controversy that I will say that makes it hard is that there's kind of different definitions in regards to, well, what's an adequate response to a vaccine? For example, it was previously defined as a 4-fold increase in antibody levels over the baseline for a given serotype. However, the issue with this is what they found is that if a patient already had like a higher level, then they may not have that 4-fold increase. So it was hard to kind of utilize that criteria to really assess if a patient had a good response or not. The current recommendation is to accept at least a 2-fold response if the baseline is greater than 1.3 micrograms per milliliter. In terms of for specific antibody deficiency, I didn't realize prior to this year about the memory phenotype, but something that you can consider is that these patients may have an initial response to getting Pneumovax 23, but they would lose the response within 6 months. So say, for example, we have a patient, they come in with normal immunoglobulin levels, we get their pneumococcal titers, we recommend Pneumovax 23, and they have an appropriate response. I actually argue that based off of this information, it would still be good to follow up with them at least 6 months from the time that we saw them, because most of these patients come to us with recurrent infections, and if they had a great response, that's good, but what you would want to see is at your 6-month follow-up, are they continuing to have recurrent infections, and then consider getting repeat pneumococcal titers to assess, did they kind of decrease with time. I had a patient recently that had like 80%, and then it went down to 10% within a 6-month time frame, which would be abnormal. If you look at this table here, this was from the practice parameters for primary immunodeficiency. I forgot to mention, but in terms of when you're looking at the adequate response to vaccines, you'll find it varies depending on the age. So what you're looking at for optimal range would be whether they're less than 6 years of age or greater than 6 years of age. So when you're looking, if you're using 1.3 micrograms, if they're greater than 6 years of age, they should have protective levels for at least 70% of the serotypes. But if they're less than 6 years of age, it would be at least greater than 50%. So the parameters are a little bit different. Depending on, again, regardless of their age, there's kind of different classifications of like severe, moderate, or mild. So if it's mild, for example, for a patient that's older than the age of, or 6 years or more, they'll have a failure to generate protective titers to multiple serotypes, or failure of a 2-fold increase in 70%. If it's more moderate, then they would have less than the 70%, and if it's severe, then they have like less than 2 serotypes that they were able to mount a response for. And that would be similar for the less than 6 years of age, but instead of the 70% parameter, it would be 50%. And the memory phenotype for both, regardless of the age, is still a loss within 6 months. And I will say that sometimes it's a little bit hard to get 6 months exactly, but if it's a little bit give or take, then like 7 or 8 months, like I still think that that's abnormal, especially if they were recently vaccinated within the past year, for them to lose that response even within a year. With specific antibody deficiency management, I think, again, it goes based off of the clinical features of the patient and how often they're getting sick or needing antibiotics, because if they really are not getting sick that often or requiring antibiotics or getting hospitalized, then you can consider doing observation for the patient. Something you can also consider doing is an additional immunization with the conjugate pneumococcal vaccines, such as Prevnar. That's usually, I believe, given at least like 1 year after they've received Pneumovax. It's not something that you can do right away. I think the other thing to kind of consider as we're kind of discussing this is, say, for example, that patient had Prevnar. When can you give Pneumovax if you're going to do this? They would need to be, again, at least 2 years of age for you to give them Pneumovax 23, but it should be at least 8 weeks from the last time that they got Prevnar. In terms of for these patients, say they're having a lot of infections and parents are like, we really need to do something because they're missing so much school or missing a lot of daycare, you can consider doing prophylactic antibiotics. But again, there's no consensus depending on when you want to start. So I think this, again, goes based off of the clinical story of the patient and kind of shared decision making with the family of what they feel comfortable with, because they will require frequent monitoring as well. You may want to especially consider it if these patients have more than 2 episodes of pneumonia within 1 year, or if they're having multiple episodes of acute otitis media or sinusitis, or at least 4 to 5 episodes. You can also consider doing this seasonally, again, fall, winter times, especially that's usually when most people get sick. And then maybe you can give them a little bit of respite in spring and summertime, but I think you'll just, again, have to monitor and see if they come off of the antibiotics, how often do they get sick. For these patients with specific antibody deficiency, again, if they kind of like fail therapy in a way, in the sense that they're continuing to have recurrent infections or hospitalizations despite prophylactic antibiotics, then you can consider doing immunoglobulin replacement therapy. But the length of the treatment, it's unclear, so you should kind of always, in my mind, for some of these patients, consider doing a discontinuation to see how they'll tolerate, but that would, again, be a discussion with the patient. Here on the right here is the table with the different regimens that you can consider doing for prophylaxis of bacterial respiratory infections, and so it has it for pediatric and then also adult dosing. I feel like I've commonly used Bactrim more so than amoxicillin, since that's commonly used as a treatment, especially in our pediatric patients with acute otitis media and pneumonia and all that stuff. But these have the different doses that you can consider doing in addition to the frequency. With this, for example, you will want to know the side effects. So for Bactrim, you'll want to know that it can cause like bone marrow suppression or thrombocytopenia. I mean, there's always a risk of an allergic reaction with these medications as well. So I think having that discussion with families, knowing what to look out for, knowing what you'll be monitoring on labs. Again, for Bactrim, there's a risk of kidney issues and liver issues. So you'll want to get like BMP and LFT antibodies. And so sometimes if I have a consideration of potentially starting these patients on antibiotic prophylaxis, I'll get baseline labs prior to starting the antibiotics and then repeat whenever I see the patient again. So this ended up being blurrier than I thought, but this is basically kind of an algorithm of what we've discussed in terms of for specific antibody deficiency, and it goes through the initial diagnosis and then versus if they respond, then considering the memory phenotype and the different types of management options. It's a nice little, I think, diagram of pretty much all the text and verbiage that I used. And then these are all the references.